So on to the Thomas G. Orr Memorial Lectureship. Laura Moore is Professor of Surgery and Chief of Surgical Critical Care at the University of Texas McGovern Medical School in Houston, Texas. She serves as the Medical Director of the Shock Trauma Intensive Care Unit at the Red Duke Trauma Institute at Memorial Hermann Hospital, the busiest level 1 trauma center in the United States. She's board certified in general surgery and surgical critical care. She's an international leader in the implementation of REBOA as an adjunct to hemorrhagic shock resuscitation and active trauma research. Laura is also one of my dearest friends, as you can tell from my talk yesterday. I've known Laura since the early 2000s. She was one of our first fellows that I ever worked with when I was at UT with Fred. And then we were lucky she joined us across the street at Methodist Hospital. And we've just stayed close friends ever since. So Laura.
Well, good morning, everyone, and thank you for that lovely introduction, Rob. It's really nice to finally be here. Rob asked me to give this talk several years ago when we were at the last in-person Southwestern Surgical meeting in Huntington Beach. And of course I said yes, and then I had a long time to really think about what I was going to talk about. And we're finally here, so it's great to see all of you and meet together in person. I'm going to talk to you over the next half an hour about a topic that I'm very passionate about, and that's trauma resuscitation, and I've entitled it Blood, Balloons, and Blades. All of that will make sense to you very shortly as we go through this. So these are my financial disclosures. So we're going to talk about blood, REBOA or balloons, and blades, which is our trauma hybrid operating room. And each one of these talks or topics could be a talk in and of itself. So these are really going to be some high level overviews of these three areas and really what's the most cutting edge research and really what we're doing in Houston as it relates to trauma resuscitation. So just to get us started in terms of the burden of the trauma patient, this was a paper that came out in the New England Journal. It was a review article on the epidemiology of traumatic injury. It's from 2013, which was obviously a few years ago, but in that period of time in 2010 when this paper was first looking at 5.1 million deaths due to traumatic injuries worldwide, and that number has continued to increase over the last decade. Trauma remains the leading cause of death for patients aged 45 and younger. And what I think is really important here is that death due to bleeding or hemorrhage is the most common cause of potentially preventable death among trauma patients. And so what I'm going to talk about today really focuses on how do we prevent those deaths that are due to hemorrhage. So let's start by talking about blood. So one of the things you'll see when you look at the history of trauma resuscitation is that a lot of our advances in our understanding about how to take care of injured patients occurred during times of military conflict. So this diagram shows the last 156 years of resuscitation in the United States, starting back in the Civil War when there was the first reported case of a whole blood transfusion in the United States, not in the world, but in the United States. And then you'll see a theme throughout World War I, World War II, Korea, Vietnam. Whole blood really predominated as the resuscitation fluid of choice in the battlefield. But in the post-Vietnam era, one of the really important advances in medicine occurred, and that was our ability to take whole blood and parse it out into components. And so now you see this emergence of component therapy as opposed to whole blood, combined with crystalloid and colloids for resuscitation. And whole blood virtually disappears from the trauma vernacular from about the late 70s into the early 2000s. We really are not using whole blood, we're using parsed products. Then in 2003, again, with the emerging conflict in the Middle East and Afghanistan and Iraq, we start to see the military utilize blood transfusion with components at a 1-to-1-to-1 ratio. So we're trying to recreate whole blood with existing component therapy. Then fast forward to 2017, we started using whole blood again on our helicopters at pre-hospital, as well as in our emergency department. And now in 2021, we're back to where we were in World War II, talking about whole blood and potentially using freeze-dried plasma. But I think the big theme here is that for the majority of time over the last 150 years, blood has really been our primary resuscitation fluid of choice. Now, as I mentioned, there was a period of time in the 80s, 90s, and early 2000s when crystalloid was king. So during my training, we used a lot of crystalloid to resuscitate trauma patients. And you'll recognize some names on this paper: Chris Kokenauer, Rosemary Kozar, Fred Moore, all people that I had the opportunity and good fortune to train with. And Fred was really working on a resuscitation algorithm that was computerized. And they were basing this off of some of the work of Shoemaker. And Shoemaker's idea was if normal resuscitation is good, so normal oxygen delivery is good, then supernormal oxygen delivery must be even better. So we were giving patients large volumes of crystalloid to drive up their oxygen delivery by increasing their cardiac output. But like all good researchers, Fred looked at the outcomes of these patients that underwent supernormal resuscitation, and he discovered that supernormal resuscitation led to very high volume crystalloid resuscitation, decreased intestinal perfusion, and higher rates of intra-abdominal hypertension, abdominal compartment syndrome, multiple organ failure, and death. So this was really our first big signal in 2003 that maybe high volume crystalloid resuscitation was bad. And here's a picture, another paper came out in 2009, again, looking at resuscitation practices. And this is a picture of Fred and I from when I was a young pup fellow in front of one of our resuscitation computers in the ICU. And the details of the resuscitation algorithm are not important, but what I want you to look at is the volume of crystalloid that we were giving to patients that were traumatically injured and bleeding. Pre-ICU, so down in the emergency department, they were getting 5-6 liters of crystalloid. And then when they hit the ICU, they were getting another 8 or 9 liters. So this is massive amounts of crystalloid we're giving people. And then when you look at how much packed red cell they got, 3 to 5 units. So they were getting a very unbalanced resuscitation. And this is what resulted. This was kind of a typical really sick trauma patient in the ICU in Houston. This was a blunt trauma, arrived in hemorrhagic shock. Got 14 units of packed cells, 3 units of FFP, no platelets, no cryo. So a very unbalanced resuscitation from a blood product standpoint. But on top of that, they got 25 liters of crystalloid, which is just blasphemy today. But in 2006, this is what we did. And we thought, we were doing the right thing. Well, fortunately, we've evolved since then. And again, with the ongoing efforts with the military, 2 really important papers have come out related to blood transfusion in the last decade. And the first one is the PROMPT study. So prospective observational multi-center major trauma transfusion study. This was an NIH-funded trial published in JAMA Surgery in 2013. It was 10 US level 1 trauma centers. This was a prospective study. So it was just, we're gonna gather data about the relationship between blood products, how you're giving them, when you're giving them, and how that related to patient outcomes. In total, a little over 1,200 patients were enrolled. And again, there was no mandate as far as what you could give in terms of products. It was purely an observational study. What they found was pretty interesting. As you might imagine, there were highly variable practices when it came to transfusion across trauma centers. But one of the really interesting findings was that there was a very protective association for patients that got higher plasma and platelet ratios within the first 6 hours of their trauma resuscitation. So the author's conclusion was that higher plasma and platelet ratios early in resuscitation were associated with decreased mortality in patients that required at least 3 units of blood due to hemorrhage in their first 24 hours. So the PROMPT study was prospective observational, and it was followed by another really groundbreaking study, another NIH-funded multi-center trial, which was the PROPER trial. And some of you may have heard of this. This was published in JAMA in 2015. It was 12 North American trauma centers, 680 patients. And this was the first randomized controlled trial that investigated optimal blood product ratios for patients that were in hemorrhagic shock. And they compared patients getting a 1-to-1-to-1 ratio of plasma, platelets, and packed cells to those getting a 1-to-1-to-2 ratio. And the primary outcome for this was going to be patient mortality. So here were the main results of the study. The finding was that early administration of 1-to-1-to-1 versus 1-to-1-to-2 resulted in earlier hemostasis, fewer deaths due to exsanguination at the 24-hour mark. So this really changed our practice. We're no longer using crystalloid. We're really focused on using blood and blood component therapy. And the 1-to-1-to-1 ratio, if you think about it, you're really trying to reconstitute whole blood with that ratio of products. And we'll talk a little bit more about that in a minute. So we've got all this great data, we have to put it into practice. So at the Red Duke Trauma Institute, where I'm very fortunate to get to practice, In February 2010, we added thawed plasma to our coolers in the emergency department. About a year and a half later, September 2011, we added 2 units of thawed plasma and 2 units of packed cells onto our 6 pre-hospital life flight helicopters. And we added another 4 and 4 to our ER cooler. And then in November of 2017, we started stocking whole blood in addition to our packed cells and plasma in the emergency department. So let's talk a little bit about whole blood versus component therapy. And like I said, when you're transfusing someone at a 1-to-1-to-1 ratio, what you're really trying to do is reconstitute whole blood with component therapy, but it's really not exactly the same. So if you look at the breakdown, if you use component therapy to recreate whole blood, you end up with 680 cc's of volume. The hematocrit is lower than that of whole blood. The platelet count is lower than that of whole blood. The coagulation factors are only 65% of the concentration you would find in whole blood, but you still get 1,000 milligrams of fibrinogen. And when you compare that to whole blood, the volume is less for whole blood. It's 500 mLs. And if you're a military combatant and you're getting whole blood, you're getting warm whole blood from one of your fellow soldiers that's basically part of a walking blood bank that they utilize when they have mass casualty situations. Obviously, in the civilian setting, it's banked, so it's still cool. But the hematocrit, the platelet count, the coagulation factors, and the fibrinogen levels are all at physiologic state. So it really is a superior product in terms of the components that are within the resuscitation fluids you're giving the patient. So why aren't we using it very often? I think some people have concerns about safety, but we have certainly not found that to be an issue in Houston. We published this paper a few years ago in Journal of Trauma, looking at our first almost 200 patients that we gave low titer O whole blood to. 124 units were given pre-hospital, 165 units were given in the emergency department. And we compared that to 150 patients that got blood within the emergency department itself. And we had no difference in terms of the hemolysis panel values, no differences in TACO. We did have 2 cases of transfusion-related acute lung injury in the patients that got component therapy, but none of that was seen in the whole blood group. And I think most importantly, whole blood was found to be an independent predictor of increased 30-day survival. So if you show up at the trauma center in Houston or come in on one of our helicopters, you're going to get a unit of whole blood, maybe 2, before we switch over to the MTP cooler and go to component therapy. So will whole blood replace component therapy, or why hasn't it already? I think it's probably coming. Certainly more and more trauma centers across the US are utilizing whole blood for their initial resuscitation. And if you think about it, it has all the components of that 1-to-1-to-1 ratio, but at physiologic factor levels. It simplifies resuscitation. You don't have to grab 3 or 4 bags of something. You grab 1 bag of blood and you put it on the rapid infuser and you go. And then the packed red cell volume versus the whole blood volume in terms of the age of the blood component itself is going to be younger for whole blood, which in theory will improve your oxygen delivering capacity. There's not a lot of prospective data. We don't have a prospective trial yet like we did with proper. But that's coming. The THOR study, which is going to be going on in France, it started enrolling this summer, is a prospective multi-center randomized trial that's going to compare component therapy to low titer O whole blood. So stay tuned for more information about that. Okay, so let's talk about balloons, my favorite topic. So these are pictures of the 3 current Roboa catheters. The one in the top left corner is the CODA device. That's the first generation device that we started to use back in 2012 when we started to do Roboa. It went through a 12 French sheath over a very long 260 centimeter Amplex guide wire. It was not the most user-friendly device, but it's what we had available. But over time, technology has improved. We have the 7 French ER Roboa device, and now as of June of this year, we have a 4 French Roboa device, and we'll talk a little bit about how we're implementing Roboa into our clinical practice. So historically, we really only had one option for aortic occlusion, and that was to do an emergent resuscitative thoracotomy and apply an aortic cross clamp. So if you had a patient in arrest or peri-arrest due to blunt trauma, that was your only option. You had to open their chest, clamp their aorta, even though they weren't necessarily bleeding into their chest. You were just doing this to occlude their aorta because they were bleeding in their abdomen or pelvis until you could get them back to the operating room. We all love to do this procedure. It's a lot of fun. The residents all want to do it. It's great. But, you know, if you think about the number of times you've done a resuscitative thoracotomy and that patient lived to walk out of the hospital, it's a pretty small number of patients, at least in most people's clinical experience. But with the advent of improved endovascular techniques and technologies, we now have a second option, an endovascular option for aortic occlusion, and that's REBOA. And that involves cannulating the common femoral artery and advancing a catheter up the common femoral into the aorta, then inflating that balloon to provide endovascular or endoluminal occlusion of the aorta. So I was very fortunate to be sent to San Antonio in 2012 to be a guinea pig for a course that the US military was developing called eSTARS. And the idea was, can we take trauma surgeons with no specific vascular training or no IR training and teach them how to do some common endovascular techniques that trauma surgeons could use for their patients? And one of those techniques was REBOA. So while I was at that course, one of the other guinea pigs was Megan Brenner. That's where we first met and became really great friends. And we both went back to our respective institutions. She was at Shock Trauma in Baltimore at the time. I was at Red Duke in Houston. And we started putting REBOAs into trauma patients within a few days of completing this course. So between the two of us, we amassed our first clinical case series of patients that we performed REBOA in, again, from our two, high volume level 1 civilian trauma centers. And here's what we found. We had 8 patients. They were all very sick. They were all very hypotensive. Their average systolic blood pressure before we put the balloon up was in the 50s. And then after we inflated the balloon in the aorta, they all had a normal blood pressure, and we went to the operating room to perform whatever intervention was necessary. It took us about 6 minutes to put the balloon in from the time we started the procedure. And on average, the balloon was up for about 40 minutes in these first 8 patients. We didn't have any deaths in the first 24 hours. We didn't have any complications related to the device. And our in-hospital mortality was 37.5%. So to us, this was really proof of concept. We could do this, we could be effective. We didn't think we were killing people by doing this. And so we really started to implement it into our regular clinical practice. But as you can imagine, there have always been skeptics. Anytime you start to try to do something new, people get skeptical about it. And the thing we heard over and over again was, well, why not just do a resuscitative thoracotomy? It's faster. Everybody knows how to do it. It's got to be just as good as doing a REBOA. So in an attempt to answer that question, is one really better than the other? Again, we went to our 2 big high volume level 1 centers, and we looked at all of our patients that underwent REBOA and all of our patients that underwent resuscitative thoracotomy over an 18-month period. Now, it's important to know we excluded those patients that were undergoing resuscitative thoracotomy for something going on in their chest. So if you were stabbed in your heart and had tamponade, you still got a resuscitative thoracotomy, and we did not include you in this analysis because that patient would not have been a candidate to receive a REBOA. So we had 96 patients between the 2 centers. 72 had a resuscitative thoracotomy, 24 had a REBOA. They were very similar in terms of age and injury severity. But one of the things that we found was that the survival rate was actually better in patients that underwent REBOA, 37.5% compared to 9.7%. Again, this is a small study. It's retrospective. It's not high quality, multi-center randomized data, but it certainly showed us that REBOA was at least as safe as doing a resuscitative thoracotomy, and maybe it offered a survival advantage. The other interesting thing we found when we did this was the shift in practice at these 2 very, very busy trauma centers that were early adopters of REBOA. So the first 6 months, no one did REBOA in this study. All 29 patients were resuscitative thoracotomies. Second 6 months, 5 REBOA, 33 thoracotomies. But then in the third 6 months, the end of the study period, only 10 thoracotomies and almost 20 REBOAs. So you really see the shift in practice. And I believe this shift has persisted and is even more dramatic today at these 2 high volume centers. So with improvements in our understanding of endovascular technology, we now have a new catheter, the 2nd generation REBOA device, which was 7 French. So as I mentioned, the first device we used, 12 French, it was not user-friendly. And now we have a 7 French device. So again, we wanted to report our experience, the 2 busy REBOA centers. So we documented our first 60 patients that underwent REBOA with a 7 French. And we were getting a little bit more brazen in our use of Reboa. We were starting to put it in patients in arrest. Before, I think we were all just trying to use it for patients that were peri-arrest but still had a blood pressure. But as we got better with the technique and more comfortable with arterial access and the hypotensive or arrest patients, we started putting Reboas up instead of cracking chest for patients that came in blunt arrest. And we had a 20% survival rate, which was, in our minds, a lot better than what we were seeing for blunt arrest that had resuscitative thoracotomy. And we had a 70% survival rate for patients that had refractory hypotension at the time we decided to place the balloon. One of the things people have worried about a lot with Reboa is complications and limb amputations and those sorts of things. And we have certainly tracked those very closely at our center. In this series of 60 patients, we did have 2 vascular complications, one iliac intimal injury that got an endovascular stent graft, and the other was a narrowing of the common femoral artery that required a patch angioplasty, but no amputations or anything like that. They were both recognized early and addressed. But not everybody loves Reboa. And in fact, there's a lot of people that really hate Reboa and think we shouldn't be doing it and think it's dangerous. And so this paper is probably the most recent to come out against the use of Reboa. It was published in JAMA Surgery last June of 2019. Many of you may be familiar with this paper. This was a TQIP analysis. They looked at data from 2015 to 2016, and they did a 1-to-2 propensity score matching for patients that got Reboa compared to patients that didn't get Reboa. And what they reported was that patients that got Reboa had a higher rate of limb amputation, higher rates of acute kidney injury, and a higher mortality. So everyone was like, oh, we shouldn't be doing Reboa anymore, stop doing Reboa. But before you get on the anti-Reboa bandwagon, let's look a little bit more closely at the quality of this study. So one of the limitations with using TQIP, and many of you in the audience I know have used TQIP before to do research, is you're really limited in some of the granular details that you want to have when you're doing this kind of an analysis. So one of the issues with the TQIP data was the time frame that they looked at. They looked at 2015 to 2016. And during that time frame, for the majority of that 2-year period, the only device that was available was the 12 French sheath that was not very user-friendly. The 7 French device didn't get FDA approval until mid-2016. The other issue was that not everybody was participating in TQIP in 2015 and 2016, including the highest volume Reboa center in the United States. So none of their information was captured in this TQIP data set. There was also no way to tell if someone's amputation was because they got a Reboa or was their amputation because they had a mangled extremity. So attributing every amputation to Reboa was really not a fair conclusion to draw. We also have no information about indications. Why were Reboas placed? Did the institution or the provider have an algorithm that they were following for patient selection? There's no information on occlusion times. There's no information on zone of occlusion. There's no information on the physiology at the time you decided to replace the Reboa. So there's really no Reboa specific data about site of access, type of access, length of occlusion, anything like that. So this would be like performing a prospective study that we'll call a nationwide analysis of rib plating in civilian trauma. Our hypothesis is going to be that patients that undergo rib plating are more likely to die. Our study design is going to be rib plating versus a propensity score matched cohort that does not undergo rib plating. And we're going to use off-the-shelf plates. You can use whatever you want. It doesn't matter what device it is. We don't even care what device it is. You can use whatever you want to plate the ribs. There's not going to be an algorithm for standard indications for use. And we're not going to collect any information about the number of ribs you plate or the pulmonary function of the patient at the time you plate the ribs, or how many days they're on or off the ventilator, and whether or not rib plating had any impact on their anesthesia pain control. I think we all recognize that none of us would ever perform the study or find the findings of the study to be relevant to our clinical practice, and we certainly wouldn't use it to drive our own clinical decision-making. So my conclusion, based on the limitations of the trauma registry data that was used in this study by Joseph et al., is that in patients who do not meet an indication for Reboa at a lower volume Reboa center without a standardized protocol, placement of Roboa somewhere in the aorta for some period of time with an outdated, larger device results in higher mortality. Now, to be fair, though, prospective data with regard to Roboa is lacking. This was a study that we published in Annals of Surgery just last year. It was a multi-center NIH-funded study of Roboa use at 6 level 1 U.S. trauma centers. And this was really the world's first prospective direct observational trial of the use of Roboa in trauma patients. All Roboas were placed by trauma surgeons at the respective institutions. So we had 6 different level 1 centers. You can see them listed up there. And we really had a combination of both high volume and low volume centers to try to capture a good spectrum of the clinical use of Roboa. 80% of the Roboas that were placed by one of these 2 high volume centers. So I won't get into a lot of details about demographics, but as you can see, this is a very sick group of patients. Median ISS is 34. They were all in hemorrhagic shock with a median base deficit of 12, median lactate of 8.3. So it's a very sick population of patients. The majority were placed in the emergency department, and the vast majority all had a blood pressure of less than 90 at the time we decided to place the Roboa. And for the first time, we were able to get really high fidelity data about the procedural details themselves, including the median insertion lengths for zone 1 and zone 3, as well as the median inflation volumes for the 7 French device. We also were finally able to capture data on time. So like I mentioned before, a lot of people have been critical and said, oh, Roboa takes too long. They're going to bleed to death before you get the balloon up. But we found that the time from Roboa decision, so from the time the trauma surgeon said, let's put in a Roboa, until the balloon was inflated was 7 minutes, which is really not a lot of time when you think about it. And the median time from balloon inflation to the balloon being completely taken down across the series was a little under an hour. Not surprisingly, high volume Roboa centers were a little bit faster at the procedure than the lower volume centers. And again, this is just the more often you do something, the faster you are in terms of the procedure itself. Now, when we looked at complications among those patients that survived past the first 24 hours, relatively low complication rates. The highest complications, not surprising, were seen in those patients that had the balloon up for 60 minutes. For my own clinical practice, if you're still having the balloon up past the 1 hour mark, that patient is really not doing well and has ongoing hemorrhage that you haven't been able to control. So they had higher rates of acute kidney injury and multiple organ failure. Overall 30-day mortality for this very sick cohort was about 52%, and our most common cause of death was hemorrhagic shock. Always have to talk about complications. We're doing something new. Everyone always wants to know, yes, but what is your complication rate? We did have some vascular complications. In total, 6 reported complications. All were recognized at the index operation and were repaired acutely. There were no limb amputations attributed to Roboa in this series either. So now we've moved on to the 3rd generation. So this paper was just published this year in Journal of Trauma and Acute Care Surgery Open. The next generation Roboa device goes through a 4 French sheath. So this is a 7 French Roboa sheath, and it will accommodate 2 of these new 4 French devices. It just was FDA approved in June of 2021. And we published our experience using this in 7 brain dead organ donors that were awaiting donation. This is a very user-friendly device. In this study, our mean time from skin puncture to balloon inflation was 70 seconds. So very rapid, a lot faster than the 6 minutes we were seeing with the 7 French device. So stay tuned. And for Roboa, I will close with this quote. This was a commentary by Joe Galante, who's trauma surgeon out at UC Davis, and I'll just read this to you. There are no randomized controlled trials for Roboa, but if perfect data were needed for a change in practice, very little in trauma care would ever advance or change. Much of trauma care is driven by surgeons' experiences and retrospective studies. So for these last few minutes, let's talk about blades, which is the operating room and something we all love to do as surgeons. So we were very fortunate in Houston to move into a new trauma tower at the Red Duke Trauma Institute in January of 2020. And with that new tower, we got this beautiful new trauma hybrid OR that we call the THOR. And this OR has amazing capabilities, not only to do angio, but we can also do CT imaging. So it's really got all of the resuscitation tools that we need, as well as the diagnostic imaging, all in one suite for us to utilize for our really sickest trauma patients. So now that we have a trauma hybrid OR, we've been able to implement a couple of new processes that I think are really exciting and important. And the first one is our Helipad to trauma hybrid OR process. So as I mentioned before, the hospital system has 6 life flight helicopters. Each helicopter is staffed by a nurse and a medic. They have fast capabilities. They also have blood components and whole blood on the helicopters. And so if they have a patient that's hypotensive, that either has a positive fast or is hypotensive with a penetrating mechanism of trauma, the life flight crew patches through to the on-call trauma attending, and they have a brief conversation about the patient and decide whether or not this patient would be appropriate for the Helipad to OR process. If the trauma surgeon agrees, yes, we need to go Helipad to OR, a page goes out, Helipad to OR, and this mobilizes probably close to 100 people that are really doing all the things to get the hybrid OR ready in that 7 or 8 minute period while we're still in flight and waiting for that patient to land. You'll see in the picture below, this is our anesthesia team with our MTP coolers sitting right down here at the bottom of the Belmont Rapid Infuser. And this is what the flight crew walks into along with the trauma team and the scrub team, all prepped, ready to go to assess that patient. This has had a tremendous impact on our time to hemostasis by decreasing our scene to OR time. So hospital arrival to OR time has reduced by 94%. So our average before was 34 minutes, and now we're down to 2 minutes from the time the skids hit the landing pad on the top of the building until that patient's in the OR. And it's really reduced our surgery start times as well by about 60%. So we're tracking outcomes related to this. I don't have mortality data yet, but this is a very exciting process that we're really proud to be starting at our institution. The other thing we've done is something called STAT-IR. So those of you that interact with your IR colleagues or don't do your own endovascular procedures, we're very dependent upon them. And the way the process used to work was we would have to call the on-call IR resident. They would review the case. They would discuss it with the faculty. And it could be 30 minutes before you get someone to definitively say, yes, we will embolize that patient. And then you had to wait for the team to come in if it was after hours, which could be another 30 to 60 minutes. So it was tremendous delays in our time to get patients to the angio suite or the hybrid OR. But we met with our IR colleagues and said, can we come up with a list of patients that we think you should come in for, no questions asked? And we all agreed that these 3 indications were good ones. So Reboa for pelvic hemorrhage, active extrav requiring ongoing transfusions, or patients that we have in the operating room already that we've packed for pelvic or liver bleeding, and we need IR to come squirt and potentially embolize those patients. So we started this process, like I said, when we moved into the new building in January last year, and we've been monitoring our results. Here's our initial data. Our first 107 patients that underwent STAT-IR, you can see the breakdown. The majority were for pelvic hemorrhage, about 25% were for liver, and then our therapeutic embolization rates are listed there. And this was a very severely injured group of patients, median ISS of 41, so a very high mortality group. But despite that, we've had a survival rate in this population of 72%. And of those that died, almost all of them died due to traumatic brain injury. Very few deaths were related to hemorrhage. So I'm going to close in terms of data with this slide. And this is really what we do all of this for, right? We do all of these things because we want to give our patients the absolute best chance for survival so they can go home and be with their families and go on with their lives. So this is the recent Vizient data that the hospital just shared with us a couple of weeks ago. I've blacked out other names, but our trauma center here in the green bar is the highest volume trauma center, as Dr. Todd mentioned, in the US. And we have one of the lowest observed to expected mortality rates in the country. And again, I attribute this not only to the awesome teamwork of our whole institution, my partners, the anesthesiologists, the interventional radiologists, the orthopods, the scrub techs, everybody really works together to take care of these trauma patients. But it's also because we are very involved in research and pushing the envelope and understanding the things that we can do to really advance the care of the traumatically injured patient. So I believe the future of trauma resuscitation is already happening right now. It may not be happening at every single center across the country, but it is happening at some centers. And these are things that we all need to be pushing. We need to be pushing blood products into the pre-hospital setting. I think very soon in select places, we're going to see Reboa going up in helicopters, especially with the new 4 French device. And the whole goal of this is for us to shorten the time that a patient is bleeding so that we can improve their outcomes. Again, I want to thank everyone for being here. Southwest Surgical has been an awesome group of people, and I consider all of you my family. And it's been a privilege to speak to you today at the oral lecture. I appreciate your attention, and please let me know if you have any questions.
Thank you, Laura. That was a fantastic talk. Your medal is in the mail, so yeah, you already know that. So next up, we have the debate, which starts at 8:45. Please track Laura down later in the breaks if you have questions. I'm sure she'd love to talk more. So thank you all. Thanks again, Laura.